Thank you. So this is a case review session. We're shifting gears from subtle mammographic findings. Luckily, MR findings are not subtle, so you can see it from anywhere in the room. The problem is, how do you interpret it? So it's not whether or not you can see it, it's actually whether you want to do anything about it. Sometimes you do miss, there are blind spots even in MRI. So those are my usual disclosures. Case 21, and that's because we actually went through 19 before. There was one more that's in the syllabus, and I have it at the end if we have time, but I'd rather get through the teaching points. So this patient has had a mastectomy and a tram flap, or a reconstructive flap. As you've learned, we don't really do these anymore, or at least the plastic surgeons don't, because the women like to have their abdominal muscles. While you guys are digesting this image, there's a problem. Those of you who've attended my lectures in the past know that I am a stickler for when tissue goes black. So that's what you're looking for. Most people can see the inhomogeneity, right? There's a bright patch of fat right there. This is a photographic enlargement to focus your attention. So question for yourselves, is there black tissue? I hope you say yes. So when you have black tissue, what do we call that? What's the most clinically significant image quality problem? And those of you who've heard me talk before will know the answer. Inhomogeneous fat saturation, low signal to noise, patient positioning, or water saturation. So inhomogeneous fat saturation does exist in the region of the reconstructed breast. And there is black tissue, and that is called water saturation or water suppression or tissue suppression. So that nodule is a problem. It's not a clip artifact, okay? So the susceptibility from a clip artifact is perfectly round. It's a radius around a circle. So this is not perfectly round. So water saturation is an issue if you care about enhancement, okay? So we had to bring the patient back for a repeat study because that was not clip artifact. There's some nodule there. And as you learned on Sunday, you have to be wary of possible recurrence in these patients. Just because they've had a mastectomy doesn't mean they have 0 breast cells left. They have much fewer than someone who didn't, but they can still recur. So here's the repeat study, pre-contrast. Now you can see that nodule. It's not perfectly round or circular. It has a slight irregularity to the border. Now you can see it is indeed tissue. It's not gray. It's gray, it's not black. And then the surrounding fat is suppressed and is gray. And there's the post-contrast. It's enhancing. So that's a recurrence. That's what they look like. And they're usually seen at the interfaces of the native tissue and the transplanted tissue. Makes sense. That's where the breast cells would be. Okay, so you kind of look along the edges of the flap. You look at the native skin. You look around there and also at the pedicles. And anything that's enhancing, if it's not clearly fat necrosis, then you need to do some further workup and evaluation, and you're worried about a recurrence. Remember, to determine fat necrosis, you're going to look for that T1 non-fat set series, compare it to the fat suppressed series. Fat will follow fat signal. It is bright without fat suppression, and it's dark when you suppress. Okay, next case. These are all the surveillance follow-ups. So this patient had a very remote lumpectomy back in 1995. Had everything, though. She had the whole breast radiation, had the adjuvant chemotherapy, but now the right arm is swelling. And so there's a concern for recurrence because this is her symptomatic side and it matches her cancer side. Here's the T1 fat-suppressed post-contrast. Okay? And remember, it's the right breast that's been conserved. And it's right arm swelling. And you can ignore the little bit of atelectasis here, that's okay. But what about all this? So this isn't near-field artifact from the coil. Yeah, so it may be touching the coil, but that's too much for touching the coil. Here's the T2 fat suppressed. So this is just for comparison. This is what the coil artifact looks like. It is brighter than the side without, but this is a little too bright. And then remember, there was some skin thickening. And if you scrolled through the stack, you'll see there's also thickening. So if it looks perfectly thin, yes, you probably just ignore that. But if it looks like there is indeed skin thickening, and you can see this on an MR, then be a little bit wary. So here's another image through that. This is still the T2, but you can see the skin is thicker on the medial side compared to the lateral side. Like you could measure that. So, Byrad's assessment. I've kind of led the witness here, right? Arm swelling, it's enhancing, it's too thick. I hope you all agree it's suspicious. I don't know if it reaches a 5, like this has to be cancer, but it needs further workup. So there is focal skin thickening with enhancement in a symptomatic patient. There's the T2. Bright signal doesn't say it's benign. I mean, it could be edema, but we're not sure because of that enhancement. And then she had some lymphadenopathy too, by the way, if you were looking in the mediastinum, which you should. We all should, but admittedly, sometimes I forget. So I kind of forced myself at the end to go back and look at the localizer and all the non-breast stuff. So we have inner breast thickening, mediastinal adenopathy. This is a suspicious abnormality. And we actually recommended skin punch biopsy because we figured this is clinically apparent. And even if it isn't, it's a really large area. We can just tell the surgeon where to go. So our surgeon did do a skin punch biopsy. It was fortunately negative for malignancy. We also did a PET CT because of the mediastinal adenopathy and the skin thickening. So there was some avidity at the skin thickening site, but the lymph nodes were not hot at all, which was great. So probably just reactive. You know, these are those times when I actually, if I have even prior CT scans of the chest, it's useful. So priors are always helpful, any kind of prior, to look at the stability of findings. So we decided we'd follow her, given that there was a skin punch and that was normal or benign, and given the FDG avidity was, you know, it wasn't super hot. The good news is follow-up 1 year later showed decrease in the skin thickening. So this was a presumed breast lymphedema. So we just attributed it to some kind of very delayed edema. We don't have any better answer because we did not send her for more surgery at that point. But the moral of the story is you should work up anything that is focal and enhancing, especially in a symptomatic patient. Okay, screening. This is a subtracted post-contrast. The arrow is pointing to a finding. So that bright irregular mass, I guess, is what I would call it, because we don't have foci anymore in the BI-RADS, or won't in the new BI-RADS terminology. All right, so just looking at that, you might be tempted to say suspicious, okay? But look there. Remember on Sunday, I said, if you have this banana-shaped, crescent-shaped thing at the level of the pectoral muscle, ask yourself, did something happen? Did the patient move between the pre and the post? Did she flex her muscle? Because if she did, then the breast tissue might also have shifted. And if you shift tissue into fat, you're going to get pseudo-enhancement, misregistration artifact. So here's the pre. Here's the post. So this is what, you hear the faculty talking about just moving forward in time in place. So here, the muscle is tense. Somehow during the scan, the patient gets more comfortable. Then she relaxes and darn, now that muscle has moved forward. So this is subtraction misregistration due to pectoral muscle relaxation. Okay, just to show you again, let me put an arrow on it so you have a place marker. Let's see if that stays. So this is the leading edge of the tissue. You see what happened? It shifted. Again, this is where the fat is, and then the tissue goes there. So when you subtract tissue from fat, that gives you that enhancement. I sometimes will describe it and just say there is misregistration artifact creating pseudo-enhancement, or the apparent enhancing mass on subtracted images is artifactual due to misregistration. And I just call it negative. Okay, next case. This patient has a genetic mutation, so getting breast MRI screening, 37. Here is a AVI, cine, going through the breast. So she is asymptomatic, just getting a routine screen. This is the T1 post-contrast, so bright things are what we're looking for. And as you go through it, focus on the right breast. Yeah, right. There's some dots. Yeah, so, okay. Yeah, there's some stuff. So this is this just happens to be a delayed phase, but indeed there is a mass that stands out. And here it is on the T2 stir. It's really bright. So the only problem is it's not quite circumscribed. There's a little pointy piece here, little divot there. And then is that a septation? You wish it were, but not quite, right? So not going to meet the criteria for future BI-RADS 3 at MR, and wouldn't meet it at mammography or ultrasound either because it's not circumscribed. So we have a right lower inner quadrant enhancing 7 millimeter mass. Might even be central, that I think the nipple was a little bit skewed inward. So here we have our mass. It is bright on the stir, T2, but that doesn't dissuade us from acting on this because of the morphology. So we recommended a targeted ultrasound to look for correlate because this was at our county hospital and it is nearly impossible to get time on the MR scanner for an MR biopsy. So we try really hard to not have to do an MR biopsy. And of course, county hospital patients, they're hard to get into the system and they're challenging to bring back. Patient did not have a mammogram, started with the MR. So, okay, fine, that's good. I mean, if I had to start with something, my preference in a high-risk patient would be the MRI. But a mammography is still helpful. In this case, we did the diagnostic mammogram with the diagnostic ultrasound, looking for, hoping to see a correlate. And she was reasonably fatty. So we thought, high chance we'll find it. And there it is, we think. So these are the spot compression magnification views. And there it is, at least what we think is a good correlate, matches in size and location. And then on ultrasound, we found this echogenic mass. And we're like, well, echogenic masses, it could just be a benign something. But again, it's county. We went with the workflow in this case, and we can add on a same-day ultrasound biopsy very easily because this is radiologist-driven. We don't even necessarily need a technologist or support staff. So the radiologist decided, you know what, let's just go ahead and sample this. And we did. There is the clip. But unfortunately, see the mass? Oops. Darn. Okay. So at this point, we're doing this on the same day as her diagnostic, and it's disappointing, but we did tell the patient that, unfortunately, the ultrasound and the mammogram, those were two different findings. But now we're also saying possibly a different finding from MRI. So when I have three different modalities, I always prepare the patient at time of biopsy. I consent for discordance. So at this point, worst case scenario, really bad day, I have three different things. My hope is that the three are one, but now I already know I have at least two different things. And I explained to the patient that, we try to go with the easiest, most well-tolerated intervention, but no matter what, each of these findings needs a biopsy. She is a high-risk patient. They generally understand when you explain that you are trying to be careful. Your goal is not to miss cancer. And a benign biopsy, that's good news. So that's okay. So we also decided we better double check whether it is the MR correlate or not, because that will help, help give us a little more closure. And there's an ultrasound MR visible clip at the arrow. So we use a clip that hydrates, so it's really bright on T2, makes it easier to find. If you don't have that luxury, if you have a different kind of clip and it's titanium, you can always do your non-fat sat T1, increase the TE time, you just have the tech run it a second cycle or go to the second TE, and that will make it bloom more. So it will be more obvious and visible. And then make sure your fat suppression isn't too severe, because if your fat suppression turns fat black, you obviously aren't going to be seeing the black clip. So I kind of like an 80% gray. The techs laugh at me because I actually titrate the degree of fat suppression. So anyway, here's the clip. There's the mass, which was bright on T2 conveniently. So we knew that just this axial T2 sequence non-con would be sufficient. And these are the kinds of scans that we try to get the patient squeezed in between regular patients. And we just, negotiate with the technologist and say, you don't need an IV. She's already had an MR. Just put her in the coil and scan. So the clip's separate from the mass. We have ultrasound, MRI, discordance. We do want to, of course, check the pathology, because what if it's cancer, right? Then that's a different workflow. Then they go on to see the surgeon, and then the surgeon and oncologists decide with us what additional biopsies to do based on management. But luckily, this was an angiolipoma. Makes sense for hyperechoic mass, and benign concordant for ultrasound. But we still have discordance with mammography, and we've proven discordance with MRI. So now, do we sample at mammography or do we sample at MRI? Well, the mammographic finding still needs resolution. So unfortunately, we go next to DBT biopsy or stereotactic biopsy. So here, whoever is doing this one, and actually it was me, I was very happy. I shouldn't miss, right? Because I have a clip marking where it isn't, and I know it's nearby. So there is a beautiful, field of view that my tech got for me with the clip. And then there's the mass. Don't miss that. That's the target. And of course, put in a different clip when you biopsy the mass under DBT. So we go ahead and do that. The mass is obscured by artifact, and matching up the CCs as best I can, it looks like the clip is in the right place. So no non-visualization of the mass, and clip is in the right location. Great. So at least my DBT biopsy I would consider successful. Because remember, specimen radiograph doesn't really help me here. I just do it to make sure there's tissue and not just fat in the cores. So we did do a clip check MRI. The mass is removed, and the T1 non-fat sat shows the clip from the DBT biopsy, and then also confirming that the mass, actually this arrow's in the wrong place, but the mass was here. That's the pre-scan. So the different positioning, and also the beauty of PowerPoint, it kind of elongated my image. Anyway, we did prove DBT MR concordance by doing a non-contrast MRI to prove the clip is now in the MR mass. Yay. So two different things. And this turned out to be a tubular adenoma, which is a benign variant of a fibroadenoma. And the good news story is she's done, and hopefully she will come back for screening again next year after going through all of this. But my own experience is that the patients actually are very grateful to realize that we're looking at this level of detail, that a small 7-millimeter finding is visible at MRI, and even in this case at mammography. So screening is good. This is going to allow her best chance at early detection. Okay, next case. Now we're moving to extent of disease. So newly diagnosed cancer, we're trying to figure out, is there anything else? Here is the early post-contrast first phase subtracted MIP. And there's a lot of background. Okay, so not an artifact. This truly is the subtraction. This isn't just a MIP of the first phase. Okay, is there something else? She's got cancer. So I find it very reassuring when, in spite of a lot of background, I can still find the cancer. So just to point it out, it's this, okay? And it's this. And there's a clip in it. And then we have all of this. And there's the color. Okay? Yeah. So this color was real. It's not artifactual. I withheld some history, but this is a very characteristic look for it. When you see these more fluffy looking areas of enhancement and fluffier tissue, I bet if I showed you a mammogram, a lot of you would get it because you're used to seeing this at mammography. And if not, okay. She is 37, I think. Well, in our practice, even a 42-year-old could be pregnant. So yes. She's 32, but she's at 39 weeks of gestational age. So that's why we did give her gadolinium, because they're going to deliver her. So if they're going to deliver soon, we will give GAD. Usually we don't give gadolinium to pregnant patient, but this is a person who has a known cancer and shared decision-making, et cetera. So anyway, there's the ultrasound, really scary mass with that echogenic rim. So that's not good. This was an IDC. MRI was performed. The MRI was performed postpartum, but I would do it if I know that they're going to deliver her soon. I used to do this in GU days when I was looking for placental implantation abnormalities, although you talk to the GU experts what people do these days. Extreme fibroglandular tissue, so her mammogram whiteout, and marked BPE. That is how it looks when they're lactating. And the good news is usually it does stay in the periphery. And like I said, it looks very fluffy to me, very soft and very symmetric. And then the enhancement of the IDC, it's a little brighter than the background. So our own experience is you do see these cancers above the lactational changes. And so we feel that MR does still add value. In this case, DWI was beautiful. So diffusion was able to point out the bright tumor on DWI, and then it is nicely darker than background on the ADC map. That's the quantitative map that comes with the diffusion, and there's the DCE. So even just a DWI without contrast in this case would have shown us the tumor. So just to remind you all, as Chris Comstock explained, diffusion is a way of probing microstructure based on water motion. It's Brownian motion of water. And you don't need gadolinium. It's not invasive. The brain, we know, it works really great for stroke and a lot of applications. Body MR is also using it. We're still kind of learning how to use it in breast. And I think that relates to the image quality issues. And believe me, I'm working with the vendors and trying to even get within our own system, because I'm a multi-vendor place, to get all the diffusions to look good enough that my clinical radiologists are willing to look at them. So just a reminder, on DWI cancers, tumors are bright. On the so the qualitative images, as I call them, you look at the high B value, in this case, B800. ADC mapped cancer is dark. DWI is qualitative, ADC is quantitative. So for research, we actually measure intensity on the ADC. It's millimeters squared per second, so it's measured as the rate of diffusion of the water molecule. And you do need at least 2 B values in order to get an ADC map. So usually 0, 800. If you have a fancier scanner, you can even try 1,000 or 1,200. But even at 1.5, we can do 0 and 800 usually. I can talk to anyone about that later if they want to try this. Okay, new case. Patient had remote left lumpectomy. I am showing you the right breast because that's where the action is. 2 groups of suspicious calcifications. 1 is upper central. Number 2 is lower inner. And this is where at diagnostic, if I see 2 different groups, I actually number them so that people know, because I'm the one who spent all that time trying to figure out which is which. And that way, when someone is going to do the stereo, then they can be sure they target the one they want. Also, I do this in case one is easier to get than the other. And I will say, sample 1, that'll be representative for both, okay? Just to give us an out, and especially if it's me, right? So MRI is recommended for further evaluation. And by the way, that's because we couldn't do the stereo, so this is problem-solving MRI. And oops, do you guys see that? No correlate to the calcs. We had clumped linear NME extending to the nipple. Left breast had a mass, okay? and associated posterior non-mass enhancement. So this is a kind of a plug for doing MRs in the patients who've had personal history, because they are at higher than average risk. And because the patient was dense there, it was just completely hidden by the dense tissue. So this is suspicious. No ultrasound correlate for the right NME. When we're doing it for a mass, we might as well just see if we get lucky. This was LCIS. There's the ugly mass, and this was IDC. Okay. 61-year-old newly diagnosed IDC on the right. You can see that on the MIP. Okay, clip in it. Additional sites of enhancement. Classic question, is it background? Is it abnormal? Let me just show it, because I want to make sure I give us time to have Q&A at the end. So there is the T1 axial MIP, sagittal, coronal, okay? Let me show you the biopsy of the NME, which was DCIS. Okay, so all of that area now is suspect, because that's part of the DCIS. What about all these other dots? Well, if you weren't sure, you could sample one. In this case, I'd probably pick the left side. But given that these are more loose, as opposed to the non-mass enhancement that we sampled that was more clustered together or more confluent, then we decided to call that benign background parenchymal enhancement. So in this case, it was the more confluence of the NME. Okay. This will be the last case. This patient had swelling, okay? And that's an implant that is really squashed down here. It's a saline implant. And this is all of the, quote, fluid, solid, who knows. So FNA was performed. We aspirated for cytology, because, these days you're worried about implant-associated lymphoma. Here's the breast MR. Okay, so that's a saline implant. You see the valve. And this fluid is squishing that left saline implant. So this isn't one of those dual lumens. And there's a rind of soft tissue along the fibrous capsule. And I show you this case because this is kind of the worst I've seen. We don't see the implant-associated lymphoma that frequently, thank goodness. But now that we're all aware, any fluid, big-time fluid collection around an implant, I first exclude hematoma and then, think about possible cancer. So there's the post-GAD and the kinetics. Right, so this is a time when you do give contrast. And indeed, this was implant-associated anaplastic large cell lymphoma. So just a reminder to be aware that in patients who've had mastectomy, you still need to worry about cancer sometimes. So in terms of my general approach for BPE versus suspicious non-mass, you're going to look at the typical patterns. If it's suspicious morphologically, if it's unexplained asymmetric enhancement, think of calcification distributions, linear, segmental. Or if it's really confluent, like the case I showed you, do a biopsy. Thank you very much.